Let's get started. So, we're going to go over stroke. And so if you read the book, let's go ahead and read it from it, and then we can explain it more in detail. So stroke on page 77, strokes, also known as cerebrovascular accidents, they'll be abbreviated as CVA, or brain attacks, involve a disruption in the cerebral blood flow secondary to ischemia, hemorrhage, or embolism. Stroke is the 5th leading cause of death in the U.S. and affects more than 795,000 people annually. Stroke is a medical emergency and treatment should begin immediately to prevent or decrease permanent disability. There are 2 classifications mainly, which are hemorrhagic or ischemic. Ischemic are more popular, accounting for more than 87% of all strokes. Now, hemorrhagic is like what it sounds like. You're hemorrhaging. This is usually secondary, it'll say there, right, to a burst or ruptured artery or an aneurysm. Okay? So I drew this one right here where this is the blood vessel, right, and keep on splitting, and then there's a burst and it'll bleed out. Now, when it starts bleeding through there, wherever this artery was gonna go feed, now has decreased amount of perfusion, right, blood flow, decreased amount of perfusion, and on top of that, as this blood begins to pool here, there will now not only be decreased perfusion, but an increased intracranial pressure from the blood that's now pooling into the brain. Does that make sense? So you're essentially bleeding into your brain. This has a poor prognosis, more risk of dying or suffering permanent disability. A very poor prognosis. If they are able to stop or evacuate the bleed, then it improves significantly, but it's very difficult to treat, requires surgery, very poor outcome, generally. Okay? Now, ischemic, kind of like relating back to MIs, as we're familiar with the word, ischemia means right there is like a lack of. There is low perfusion, very diminished, right? So you have good blood flow, but if there's a crappy blood flow, not enough getting there, there's a decrease of the amount of oxygen being provided. That area will slowly suffer, and if long enough, can start causing death of that tissue as it's not receiving enough oxygen. So ischemic is that blockage of circulation, and there could be both. It could be thrombotic or ischemic, right? It could be one of the two. Thrombotic, this implies a thrombus was formed. Now the difference between a thrombus and an embolus is that the thrombus has formed there. So let's pretend that there is, right, like a clot or a plaque that is forming. Since it is forming here, this is a thrombus. That's where it started, that's where it's forming, just getting bigger and bigger and bigger. That's a thrombus. Should a piece of this or the entire thing detach and then begin to travel into your circulatory, begins to travel, now it is embolus. So while it is forming there, and that's where it started, thrombus. The moment it detaches and becomes a traveler, embolus. Okay? Now, obviously, some of these clots can form right in your deep vein thrombosis, things like that. And if one of them detaches, as it travels, if the clot is big enough, it won't be big enough to continue traveling when it hits a vessel that's too small. It'll clot it, right? When it eventually hits a smaller vessel. So, if you have a thrombotic, I drew a plaque here, right? It's slowly forming. You can see how the blood freely flows into that one, but in this one it becomes so diminished. It's a trickle. So a blood clot where the plaque is formed, buildup is formed, right, and blocks. So it's slowly getting bigger and bigger, slowly occluding. The manifestation will develop over hours to days. Okay, as that trickle becomes smaller and smaller and smaller, as that plaque has become more and more occluded. So you start noticing, you know, those manifestations over a few hours, maybe since yesterday, but it's not fully there. They're not like full on, right? Like already like halfway drooping and weakness immediately. It's been slowly going on. They can also have TIAs, which are transient ischemic attacks. It can be due to spasms or other things. That's where people can have these symptoms for maybe minutes or less, and then it goes away and it's not even a thing anymore. And it's in and out. They're transient. But in a full-on thrombotic, you'll see that it slowly is progressing. It's not in and out, but slowly. As opposed to if it was an embolus, well, everything's fine, and then here comes the embolus and boop, clots. Now it'll develop almost instantaneously, right? Very immediately, you start having a severe, right, downhill of paralysis, grouping, altered level of consciousness, the full effects. Because again, it suddenly just occluded the vessel. So, in seeing just some of these manifestations, understanding how they work, you can almost by description assume what kind it is. Does that make sense? So somebody suffering a stroke, it's like, okay, well, is he bleeding? Is it a clot? Is it a form there? Like, what's happening? So that's why you'll see that, and we'll go down the road right now where we ask, when did it onset? How did it start? What are you noticing? Their previous medical history, right? All of these things matters in trying to point out what's the most probable thing that's causing the stroke. And of course, CTs, MRIs will be able to determine what's most likely there, or at the very least, whether it's hemorrhagic or ischemic. There's a blockage or not. And this will determine the treatment. Now it goes to say that if they are ischemic and it's from blood clots, you can give TPA. These are the ones, hemorrhagic are not candidates for this. Ischemics are candidates for something called TPA. Okay? And this will dissolve the clots. But the time frame for this is if they've been started at least, right, within at least the last 3 to 4.5 hours. So less than 4.5 hours. You need to have been started before less than 4. So if their stroke has been going on longer than that, it's not advisable or not really good candidates. Yes? All right. So, of this, health promotion, something you should be familiar with, right, is the be fast. But now some of them I'm going to do it as at least just fast. So things that you should assess for, I can indicate this is a facial droop, arm weakness, speech, or they'll call it slurred speech, right? Or their speech is altered, speech impairment, difficulty speaking to you, they can't phrase what they want to say, they're slurring. So that's why I just put it as speech, but some of the little brochures, whatever, you'll see it says slurred speech. But it could just be speech impairment is really what it is. Any type of speech impairment. And then the time. Time is of essence, right, in this situation. So make sure that you're identifying and acting for this. Okay? So risk factors for stroke. Cerebral aneurysm is one of the biggest. AV, arteriovenous malformation, bad vessels, ethnicity, people that are higher for this at risk are Black Americans, Hispanics, and indigenous people. Family history. Additionally, being more than 65 years old. So there's more in older adults, especially the ischemics. Diabetes mellitus, obesity. Big ones here are going to be these diseases, the diabetes, obesity, hypertension, hyperlipidemia, right? High cholesterol. Hypercoagulability, like if people have sickle cell disease or clotting disorders. Heart disease, more specifically, AFib. Alcohol, smoking, substance use, and so I'll put here drugs, and oral contraceptives. And I need that to be a very big emphasis. It's so commonly asked now. And you'll see this when we go into OB even more, but I mentioned it in repro. Like especially the oral contraceptives that contain both hormones, they're not great for, people who smoke, have history of, heart attacks, hypertension, alcohol consumption. All of these things increase your risk of clots and ruptures, and the oral contraceptive does too. So ideally, you don't want to give it to people with a history that are tobacco smokers. It really feels like, in some cases, that you're trying to decide between a baby and a stroke.
And what did you pick?
Yes. Pass. Now, why AFib? Your heart looks more like this, right? At least inside. Yeah, it's better to draw like that, like almost like a butterfly, and the left ventricle is the biggest. Now, in AFib, these top ones are not pumping effectively. You want a squeeze, and all the blood should come down straight into the ventricle, and there should not be much left into the atrium. But in AFib, since it's just like quivering, by gravity, when the valve opens, this blood trickles inward to the ventricle. But a lot of it is still remaining and can pull inside the atrium. And as the blood just kind of stays there, it'll form a clot. And then that clot will eventually go into your right ventricle, and after that will be shot into your lung. Pulmonary embolus. Okay? So that's why people on AFib, well, we don't really try to control it if it's not that bad, right? There's no reason to control the rhythm. What are they going to be started on? Digoxin and anything else like that. These cardiac medications are used to control the rhythm if it's really a problem, if your dysrhythmia is that severe. But in most cases, they don't treat the dysrhythmia, right? You're going to just prevent coagulation to prevent the complication. Generally is the one that's being pushed a lot more right now. It's really expensive too. Yeah. Get yourself a good job, or a spouse with a good job that puts your medical insurance. I know it doesn't matter when you're 19 and can eat a cup of noodles and vodka and you're fine.
You want it when you can.
But when you're 28, 30, you want some medical care, okay? When things start hurting,
Get it while it's still cheap too.
I'm to myself, but if the shoe fits.
I think they think you're older than you are.
Yeah, that too.
It's all the drinking from before you stop.
Maybe. I think it's the lack of sleep. Say that wrinkles matter. And it's like
I'm just saying it's never too young to start doing some different kind of.
Yes, it is. I'm like 24 years too late.
Start using some other guy.
you look worn out. Visual ability
Vertical?
is impaired. Confusion. Unilateral, meaning one side. Numbness, tingling. And we talked about TIAs, and usually these symptoms will resolve within 1 to 24 hours. They go away, but something is brewing there. Okay, physical findings, things that we'll see, right, is hemiplegia is another word for it. For this one-sided weakness, right? Hemiplegia or hemiparesis, which is weakness. Okay. What else? Expressive and receptive aphasia, which is their ability to communicate, right? To talk. Agnosia, difficulty recognizing objects. Alexia, difficulty reading. This, like, look at the word between and this. Right? So when you say this, it's usually like a dysfunction. Like, it's not that it's completely gone. That usually implies an and or as the prefix. When you see this, it means like a dysfunction usually used. So when you have dyslexia, it's not that you can't read, but you can't read functionally. You have an impairment towards it. You mix some of the letters, but overall, they read. Right, so in Alexia, they're unable to read. Or they're unable to recognize the objects. So when you look at your NIH stroke scale, right, you see that one of the things is they just show a picture board. And it has different things like a cactus, a clock, a shoe, a car. It's just different objects within the picture. And you tell them, like, what's this? And they have to tell you. Or you tell them, point to the cactus. And they have to try to point to it. So they have to recognize the familiar objects because they have trouble remembering. Or recognizing, I should say, not remembering. Okay? They're gonna have trouble speaking, right or left-sided weakness, ataxia, which is muscle coordination, right? Being able to like have symmetry. So like loss of balance, which you can consider this. No depth perception. Okay, so I'm writing some of the most common to you, but any of the physical findings are fair game. These are all things of stroke, but I try to write out or point out to you the most common that are seen. Okay, so take a moment to write those down, highlight your book, and then we're gonna go into the labs and diagnostics. Checking more specifically what? H&A. Platelets are big. Coagulation panel. I covered this earlier. What's your coag panel? ET, INR, PTT.
Is it PTT or AT?
It is the same thing. Okay? Dopplers. What do Dopplers do? It helps look at your blood vessels if there is flow or clots. Blood vessels for flow or clots. MRIs for visual of the mass of the brain, and then more importantly, an angiography. And for angiography, at the beginning of this last week, we covered the specifications of what to check, especially when it's with dye or without. And lastly, dysphagia screening. Oh, still obsessed.
We're still there.
How do you know, what's an easy way? I'll give you guys just one so you don't get caught doing something horrendous. If your patient has a stroke, maybe they switched to diet, maybe they did it. By the time they get to SNFs, usually they're evaluated, there's a plan of care, right? It's ongoing, but you never know. People could miss things. How do you know when a patient is not probably tolerating their diet well and they need to be evaluated again with the speech pathologist? What are they? They can pocket food, the cough. If your patient coughs after swallowing, then they're most likely having issue swallowing the food wholly, hence they're coughing. The reflex is still there. Now, what's the danger with people, especially with strokes? Not as much Parkinson's, even though it can happen, but with strokes, what's the problem? Some of them will not cough. The reflex is so far gone that they're aspirating. They are swallowing food into the trach, and it's going to their lungs, and they're not coughing. Their reflex is that far gone. So then slowly what's happening to them is they are having aspiration pneumonia. And then in the sniff, if it goes uncaught, you're sent to a hospital, and that's where they'll see on the x-ray or other imaging that they're having pneumonia. And without infection or certain things, or if they catch, the speech pathologist sees it, they'll be like they're aspirating. You don't wanna get in trouble for it. So make sure, like, even if they cough just a little, well, I mean, obviously if they're sick or something's happening, I can get it. But if they're usually fine, you know, or you give them food, but they like cough a lot, something's not right. Okay, especially like with like an episode, I can understand like somebody clearing their throat, okay, where they double swallow, that's a good practice, double swallow to get it all down, okay. But if you give them a spoonful of soup or like a thin liquid, like just regular liquids, and then they're like coughing a lung out, they're coughing a lot, coughing a few times after every time that they're eating, they're not tolerating it well. So you should report it. There's nothing you need to do other than say something and document it, like report it to Word so people know that you did it. Make sense? Now, per ATI, I know in real life, you're gonna be like, well, in real life, but per ATI, anybody with any type of dysphagia or aspiration precautions, the AP cannot feed the patient, only the nurse can, okay? Now, in real life, as we said, I get it, everybody feeds them, but, right, usually they're in long-term care, we already kind of know the diet is there. But especially like in an acute setting or per ATI especially, the nurse should feed the aspiration precautions patient of the dysphagia.
Is it the whole time or just like the first couple of times?
I would just say that all the time. Unless it tries to like very make it specific that they've been on the diet and there's something more severe, then I would, but I don't think they'll go that far. I just know that in the delegation that we went over, it says that they're able to feed without swallowing precautions. So if they have swallowing precautions, they usually shouldn't.
It's like vitals for stable and not unstable.
Right. Don't forget how you're supposed to do these MRIs and angiographies. Just let us slow down here. We covered all of these exams in detail at the beginning of the module. Okay, so I think that's a big misconception and something that ends up happening. At least in my class, where like I go over all these diagnostics with you in detail, and so when we cover it, because they're gonna continue to come up every disorder. We're seeing it for headache, for stroke, for meningitis. We're seeing lumbar puncture, MRI, CT. This is like standard. because you're trying to determine. So I explained the diagnostic in the beginning, because I'm not gonna re-explain MRI every single disorder that it comes up in, because it comes up in every one. That's why you understand MRI of the head. Does that make sense? So just because it doesn't get slowed down, doesn't mean it doesn't apply for it. You're applying the MRI diagnostic procedure teaching already. Don't forget. Yes? Okay. So, we still got quite a bit for stroke. I like to take my time on it. It's a very, very like frequently asked thing, especially in med-surg. We only got 10 minutes and I'm not gonna rush through it. So we'll pick this up tomorrow with neurosensory.